Okay, hi. My name is Teresa Purzner. I'm a neurosurgeon scientist at Queen's University with a focus on neuroncology. And so I am delighted to be here today talking to you all about how we're using a sort of non-traditional approach to creating a patient and physician-centric neuroncology program. And so the approach we're taking is design thinking. But let's just take a step back a little bit and talk about how we got to trying to even solve this problem. So my background is actually, from a research perspective, much more so basic science. A lot of my time is spent in the lab working with cells or mouse models of cancer, trying to create targeted therapies for pediatric brain cancer and trying to create ways of performing personalized precision surgery for adults with brain cancer. And the inspiration for this project came very sincerely from witnessing a fairly substantial unmet clinical need, particularly for patients in Canada. And that has to do with patients newly diagnosed with brain tumors. And so, as a lot of people know, receiving the diagnosis of a brain tumor is this very overwhelming diagnosis. And immediately afterwards, you have to go through a tremendous number of steps to get the level of care that you deserve. So from first presentation to the emergency department, to getting imaging, to getting your diagnosis, getting referred to neurosurgery, getting to surgery, having surgery performed, and then moving on to get radiation and medical oncology, a lot of this happens within the first weeks of your diagnosis. And everyone in this healthcare system knows how hard it is to even get in to see your family doctor or to get that MRI. And so coordinating all of it is challenging, and it's confusing for the patient. It can be quite overwhelming. And on the side of the physicians and the healthcare workers, similarly, it's a tough thing to coordinate. And as a result, a lot of things fall between the cracks, and when things fall between the cracks, there's delays in therapy. And as you can imagine, with this many steps, if there is a failure of any one step, then all the ensuing steps are delayed, and that happens again and again with each delay. With primary brain tumors in particular, patients diagnosed with GBMs are particularly sensitive to these delays. And the reason for that is that untreated survival can be measured in months. And so every delay, every week of delay, even every day of delay has a significant impact. When I was trying to figure out, how do we solve this, it became pretty clear that fixing any one step wouldn't solve the problem as a whole. Maybe we can arrange things so MRIs are more streamlined and require less paperwork on the side of the physician and less advocacy on the side of the patient. But if we fix that one problem, there's 16 other problems that are still waiting. And so because my background is not in quality improvement or even really clinical research, I went to and found my good colleague and a brilliant researcher, Dr. Katie Goldie. She's in the School of Nursing. And together we brainstormed, how do we fix this problem? And ultimately what we found was traditional QI approaches might not be effective or efficient in the problem at hand. Again, solving any one problem wasn't going to solve the system. And so I went back and leaned on a very different experience I've had professionally, and that's the experience of entrepreneurship. And so I certainly won't go into details of this, but during a couple of years ago, I founded a baby food company that really grew, and now we're quite large. We're in over 12,000 stores. And what this taught me more than anything was the incredible efficiency and user-centric approach of entrepreneurship. And my question was, can we take some of those techniques that create this very, user-centric and adaptive approaches, and can we apply it to an academic neuro-oncology program? And in particular, could we use design thinking? So what does that mean, and why is it different? Well, if you think of the traditional scientific method, which is how we approach a lot of things in healthcare, you start off with a problem, you then create a series of tests to assess the problem. You come up with a hypothesis, and you either reject or validate that hypothesis, and ultimately you come up with a potential solution that you then go on to publish. Design thinking is almost the opposite approach. So instead of starting with a problem or a question, testing it and finding a solution, you instead start with the solution. So you start with the solution, you then empathize with the users for whom the solution is relevant. You prototype a potential solution, and then you go out and test it. So let me give you a few more concrete examples. And again, design thinking can be used for many things, but it's probably most commonly employed in the world of business. So let's say you're trying to make an app, a travel app, and you're using now, more of a scientific approach. You say, okay, well, most of the travel or the meal apps right now don't take into account whether or not a family has kids, right? And so the problem here is that current travel apps don't include whether or not you should take into account kids. Okay, so I think that creating an extra button that allows you to push on it to say how many kids you are will meaningfully improve a travel app for families. And so you make that prototype, you go out, you test it, and you see whether or not families liked it. And they say, okay, I think there was a 20% improvement in my experience by having that little toggle. That's sort of a traditional approach where you're coming with a question and the presumed solution. Design thinking is the opposite. Now you're starting with a solution. So you're saying, I want to create a travel app that best meets the needs of a family. And that's it. No hypothesis as to what that travel app looks like, no potential solution to go out with. You just want to do this really nice thing. You then go out and you talk to many, many families and you say, okay, what are the pain points of the current travel apps? What would you want in the travel app? How does that look like? And how can we modify what we're doing to best meet those needs? After you've had that very large empathy step, you then go on and create a model or prototype based on the feedback you've given, and then you test it and you see how do people like it. The other issue with design thinking is that unlike this, question answer publication approach, it's a very circular and an iterative approach. Once you have that first prototype, you are launching it with the assumption that it's just that. It's a polished prototype. And then you go back again to more families and say, okay, here's our first shot. How did it look? What worked? What didn't work? And you iterate. You just keep iterating by going around this process over and over. And so for me, when I was thinking of, how do we create a great neuro-oncology program, it seemed like the second method made a lot more sense because we're not trying to solve one problem at a time. We're trying to create a good program, and we're depending on the users of the program, in this case, the patients and physicians, to tell us what does that program look like. And that's how we started the design thinking process. So again, unlike normal hypothesis-driven scientific approaches, design thinking is solution-focused, it's human-centric, and it's rapidly adaptive. If you were to describe it in three things, I think those three terms would probably summarize it best. So off we went. We said, okay, we're going to take this untraditional approach to creating a neuro-oncology program. Let's do some design thinking. These are the 5 steps of design thinking. It starts with empathy. You then define the problem. You ideate together. It's basically the brainstorming session. Then you create a prototype based on what you've learned, and then you test it and you do it again. Like all design thinking processes, we started off with the empathy step, and we went pretty deep with this. So in business, again, empathy is usually primary and secondary market research. So primary research, reaching out directly to the users, and secondary research, understanding through third parties what's worked in the past and what are the pain points in the past. And so we did a similar thing. Instead of talking to customers, we went out and talked to the actual people who are engaging with a neuro-oncology program. So that's patients, it's physicians, it's allied health, it's healthcare admin. We had coffees in rural communities and met with rural meters to get their thoughts on how things are going and the unique needs of their populations. We talked to Indigenous advisors. We kind of really went as broad as we could and had either focus groups or conversations with them all. For our secondary market research, what we did is we did a retrospective review of the last 1,500 patients who had had brain tumor surgery in Southeastern Ontario. And then we reached out to a lot of the well-established foundations and programs. So for example, the Brain Tumor Foundation is the resource that we leaned on very heavily. And you'll actually see the very obvious impact on the expertise and resources of the BTF on what we finally came up with. After all of this, we sat down and then we decided to define what our scope was, at least. And you'll see that there was a pretty big change before and after the empathy step. So initially, we wanted to improve the flow of care, and we wanted to improve 30 and 90-day mortality rates. That was the initial goal of creating a brain tumor program. After the empathy step, the scope was far broader. And so, early education on what's happening, what to expect, when you should be expected, a single touch point throughout the journey. So having someone that you can reach out to because you're going through so many different specialties, having a unified navigator that can help at least direct you in the right direction was seen as very helpful. Having standardized referrals, improved coordination and collaboration in research initiatives, and access to cutting edge research. And so we took this very narrow original scope, and through the empathy step made it quite a bit broader based on what people were telling us. We also came up with the vision of the program, which is to provide the highest level of care to every patient in Southeastern Ontario diagnosed with a brain tumor. Again, initially, that was our first vision. After the empathy step, we included irrespective of where you are and who you are. So a really big learning that came from the empathize step, particularly through the retrospective review, was the sociodemographic impact on outcomes and access to care. And so we found patients from smaller communities did worse in terms of flow of care and even mortality rates at 30 and 90 days, and considerably worse. Interestingly, how far you were from the tertiary center providing care was not correlated with your outcomes. So it's not a matter of it being hard to get to your appointments, it's a matter of rurality. Also why we spend a little more time and focus speaking with rural patients. Then we went on to prototype. Okay, so we empathized, we defined what we wanted to do. We had a big brainstorming session. We created a leadership team that was overseen by Katie and I. And then we decided, okay, how do we take all this information and this structure and make it into something that's actually useful to patients? And we did it in many different ways. I think because the feedback was so broad, our approach to solving it was similarly pretty broad. One big thing that we came up with that I'm very proud of, or introductory bags that go out now to every patient newly diagnosed with a brain tumor. It has resources there. So some resources that we made ourselves, brochures that are pretty targeted at specific steps in your journey. So the time between diagnosis and your operation, or the time between your operation and initiation of adjuvant therapy. Something that was identified in the empathy step was that a lot of patients were having a hard time being able to find transportation and afford accommodations. Southeastern Ontario has a very large catchment. We have the greatest rural population of any catchment in southeastern in Ontario. And so how to get here and how to afford staying here for your 5 days a week for 6 weeks radiation was something that was the struggle. We actually also found out in the empathy step that there are resources available within Kingston to provide funding for hotel stays. And there was actually quite a few resources for transportation where the patient doesn't have to pay for it themselves. And so coming up with just a very specific one-page document on here's what's available, here's what we can do for you, here's who you call if you need help. We also came up with prospective data collection tools and also navigator assessment tools. And what this allowed us to do through a pretty quick questionnaire is identify what possible pain points an individual patient will face in the next couple of weeks. And then based on what was identified, we could send out appropriate consults. And so again, if transportation is an issue or if mental health is an issue, then an early referral to psychosocial. If long-term life planning is an upfront issue, it isn't always, but sometimes it is, then an early consult to palliative care. So those discussions can be had sooner than later. Again, it's not for everyone, and we want to find a way of identifying who it would be helpful for without overwhelming people for whom it wouldn't be. And finally, what we did is we packaged it all together in a nice bag. We also came up with a notebook for patients that can be used in addition to the brain tumor handbook. So when you're going to your appointments, you have one book where all the information is, so you're not having all these little pieces of papers between different people. The notebook could be shared between family members. So again, there's one unified place where all the notes are taken throughout all the very many visits. And then there's either a toque or a baseball cap. After surgery, you have shaved hair and incision, and some people liked, a cozy toque to put on top of it during the winter months. So just a little bit of humanity there, I guess. And again, big arrows here. Really, a huge part of that initial introductory bag is the brain tumor handbook. A big thing for me is to be lean, it's to be fast, it's to be adaptive. And so if someone has already solved a problem better than you can, in this case, it was the BTF handbook is better than any handbook we could come up with, then don't reinvent the wheel. Use that handbook and collaborate with people who are already ahead of you in specific areas. So again, the brain tumor handbook came from that empathy step. It came from the secondary market research, looking at who's doing what. And this is something that was clearly being done very well, that had absolutely no need for us to try to do better. A little example specifically of the impact of the empathy step. So this is diagnostic and treatment of glioblastoma, so of primary brain tumors. And again, it's focused on those first couple of weeks after diagnosis. So Here you can see there's what to expect when. We created time points that were specific to Southeastern Ontario, but this was hugely incentivized by the care map that the BTF had put forward. So we just adapted it to one little part of one pamphlet, but it allowed patients to recognize when they were falling between a crack. Some patients sometimes felt that if I haven't heard from the doctor, it means I don't need to hear from the doctor. That's usually not the case. If they haven't heard, more often than not, it's because a fax was lost or referral was lost. And so here, with this treatment timeline, again, largely incentivized by the care map that the BTF put together, we were able to allow patients to advocate for themselves, saying, "Hey, I should have been on this next step. It says it should have happened in 2 weeks. It's now been 3 weeks. What's going on?" So not only what you should be expect, but lower down, who do you call when it hasn't happened? So it's one thing to recognize you're falling through in between the cracks. It's another thing entirely to get a hold of the person who's going to help you move forward. And again, I think anyone in the Canadian healthcare system understands exactly what I'm talking about here. And this part, who do I call when? That was more the primary market research that told us. That wasn't what the patients identified to us as a pain point. So what bloomed from this as well was sort of more ways of interacting with us. So we have an Instagram account sort of telling people what's going on when. We have a pretty good number of people following us, so that's reassuring. We have a website with a lot of the resources and links to things like the Brain Tumor Foundation. And then finally, we have an email address. And I think this was one of the biggest things in terms of helpfulness. It's an email address that allows people to reach out to the navigator at any point in the first 90 days of their operation, their post-operative period, to help guide them towards the right next step. And again, you can see we have things like QR codes and social media and email, but we also have phone numbers because not everyone interacts with the program in the same way. Another learning from the empathy step. And then finally, it was test time. So off we end. We launched it, and the way we launched it was by visiting. The website went live, social media went live. There was a countdown actually before launch day, but on launch day, we went out that week to a bunch of the referring hospitals and some of the rural communities, and just introduced people to the program and with specific documents for emergency physicians versus hospitalists versus primary care. And how they can reach out to the QBTP and how we can help them. Of course, a huge part of this launch was taking us back to the empathy step. It's always circular, and we took advantage of that FaceTime with the physicians in allied health to again ask them, "This is our first best shot. What do you think we should have done differently, and what do you think we should do better?" And a lot of feedback from that's going to sooner than later impact the next iteration of the brain tumor program. So that was our design thinking approach to building a neuro-oncology program. It's been really fun putting it together. It's been a lot of work, but it's been a lot of fun. Always happy to hear from anyone with thoughts or interest. Here is our email address. Just email us anytime, and we'll get back to you. So thanks again to the BTF for letting me share the work that we're doing. I'm hugely appreciative of the work that you're doing, and it's a real honor and enjoyment to be working on this together. All right, thank you.